Hi everyone, my name is Kelsa Laughlin. I'm one of the MPH students and I'm part of the 2013 cohort. So I'm the only person I know here is Faye. So we've taken a long time to do this. I'm really excited to finally be at a Culminating conference. So my topic is adverse childhood experiences, also known as ACEs, and specifically screening for ACEs in primary care. I chose a black background. Bear with me, I hope this works. I don't get to make a lot of presentations, and I got really excited with bullets coming in, so bear with me. So I live in Australia. I've lived there for 4 years, and I was lucky enough to do my practicum there, which made things convenient because I did it part-time. And I just feel like I need to give a quick rundown of healthcare in Australia because it's a bit different than Canada. In the simplest sense, it's kind of in between Canada and the US. So it's a two-tier healthcare system. We do have public healthcare. It's called Medicare. It's universal. It's federally funded. We have big public hospitals, just like here. I work in one. I'm a registered nurse at a pediatric hospital. I work in emergency, and it's the same as Canada. You walk in, you don't pay. It's a nice big teaching hospital. But because I did my practicum at a private primary care clinic, I just had to kind of run through just really briefly to set the stage. But I will just skip over this because I'll get to that after bulk billing. So we do have private healthcare in Australia. We have private hospitals. We have private emergency departments. It's just very different for me as a Canadian. It gives, you can choose your doctor. You can have a private room and choose food from a menu and all types of things. But both systems kind of work together in the country. And there's also private primary care. So just a little overview in case you need a little map of Australia. I live in the beautiful state of Queensland, and I live in Brisbane. It's about the size of Vancouver, and Queensland has the population roughly of British Columbia. I'd like to also, at this point, just acknowledge the original peoples around Brisbane, which is the Yagara people, and the Indigenous population around Brisbane, and the many, many that live in Australia. So, my practicum. So I was at a place called Inala Primary Care. Inala is the neighborhood outside of Brisbane. Up there, that's like an advertising banner, and the bulk billing there in black is very important. Bulk billing means that you don't pay anything. Typically, there's a fee for service for seeing a GP or a nurse in Australia. I, out of pocket, pay usually about $30, which is sort of just what you accept because you live in Australia, and that's the system. But bulk billing is a special thing that many clinics will do in certain neighborhoods because it means you don't pay, and that's important. They advertise that or people wouldn't be coming. And Inala itself, as a neighborhood, is one of Queensland's most disadvantaged neighborhoods. And in fact, on a socioeconomic rating they did of postcodes in all of Australia, as far as disadvantage, Inala fell in the 4th percentile of the most disadvantaged postcodes. So it was an incredible place to work. It's a really, really amazing clinic staffed by amazing people. I felt really lucky to be there. They're really all about kind of helping to improve health inequities and accessibility to healthcare. So it's a great place to be. So it's, like I've said, privately run, but it's run as a charity, staffed by GPs, practice nurses, and a lot of allied health. And they saw 40,000 patients last year. At the moment, they're seeing 1,000 patients a week, so they're quite busy. It's quite a small staff. But luckily for me, they're active in academic research. They train family doctors. They're big into health promotion, and they're part of the Refugee Health Network of Queensland. And the University of Queensland very generously let me work with one of their librarians, which was invaluable. I don't know what I've done without him. And I wasn't one of their students, so it was very nice of them to help me out. And there's some nurse researchers that are keen to work on ACEs with me, which I will get to my topic. And there's a very high refugee population in Inala, so they're part of the Refugee Health Network. So the topic came up, what will I do for my practicum? And they asked, why don't you do something on ACEs? So I'd never heard of ACEs. I don't know if anyone here knows them. But the doctors and nurses and all, I hadn't heard of them either. So it stands for Adverse Childhood Experiences. And in a way, it's sort of an instinctive thing we understand. At least in nursing, I know we know it, and maybe we've learned it here with our social determinants of health that we know about. If you've had a really rough upbringing, and we had a lot of adversity, you're probably likely to have more negative health outcomes. So we sort of already know it, but to make any changes, obviously, in mainstream healthcare, we need evidence. So is there evidence? And there's a lot of it. The biggest study that came out, which coined the term ACEs, came out 20 years ago, the Adverse Childhood Experiences Study. So it was with the Center for Disease Control and Kaiser Permanente in the States, Dr. Vincent Felitti and Robert Anda. And so what they did was, after noticing it, one of them was running an obesity clinic, and a lot of the obese patients started telling them about childhood abuse they experienced. So it became more than just a coincidence, and so they went ahead and made a big research study. And over 17,000 participants, these were adults living in San Diego with Kaiser Permanente Health Center, received a 10-point questionnaire, and you get a point for every type of adversity. Whether it's abuse, neglect, your parent was incarcerated, you witnessed domestic violence, or did your parents divorce, all things before the age of 18, and you get a point for every type of adversity, and it ends up being an ACE score. So what they found was a very clear dose-response relationship. This is my really fancy graph. But basically, the more adversity you've had as a child, the higher the likelihood you'll have negative health outcomes. So this was very clear in their study, and there was a couple more things they found, that they're common. 2 out of 3 people have at least one ACE, and 1 in 8 have 4 or more ACEs. And if you have 4 or more, the following, I got really excited when I dropped down things. So, and I hope the colors show up okay, the black, but there's over 40 negative health outcomes so far that are published in literature that are connected to ACEs. And so these are just some of the 40 health issues. I won't go into all of them. I wish I had more time. I could literally talk about this forever. But in pink are the odds ratios. So that means the higher chance you'll have of having some of these if you've had adversity in childhood. And some of them are significant. Suicide's 30. And in some of these we kind of understand, again, because if you've had adversity, you're maybe more likely to smoke or drink and have health risk behaviors and more mental health issues. We already kind of know that, but there's way more to it because there's a whole thing behind toxic stress and the neurobiology of toxic stress and how it affects people, which they're still studying. So what did this mean for my practicum? Well, in all of primary care wanted to start ACE screening. So they wanted to know, can the questionnaire be introduced? Where has it worked already? And what's needed for GP and nurse buy-in? Because I'm a nurse and I work triage a lot, and they often try to hand us screening tools and we don't have time, and it's frustrating. So I didn't want to be someone that waltzed in and said, oh, we're going to do this, we need to screen for this, and they're already very under the gun. They are very busy, this practice. They don't necessarily want to be screening extra things. So the outcomes of my project, the first thing was a literature review. This proved to be very difficult, even with a librarian who helped me at the University of Queensland. Because ACEs discusses all types of adversity and the outcomes are varied, to break down search terms, trying to use the databases of, we use PubMed, we use Scopus, Web of Science, but when you break down search terms and try to put them together, it's infinite. We end up with like 20, 30,000 articles, and it was hard to break it down. So we tried to just focus on specific ACE research. I still ended up with a lot of literature to help inform everybody at the practice, but it was a lot of trying to see where it had worked in the past. So the project ended up being translating knowledge for a grant proposal, because so much of what they need to do in order to make a project function is more funding. So the grant proposal has been submitted because they'd like to keep moving forward with this. And the idea was to distill the evidence, to make 2 one-hour education sessions for the doctors and nurses and some of the research team in Inala. So a big part of it was breaking down barriers to screening. A lot of it's about time. They don't have a lot of time. And also, some doctors figured, why are we going to ask about such sensitive topics when people have come in for a broken toe? But it was more to really talk about the importance of ACEs, and I introduced a lot of my presentation to the staff there. It had a lot to do with toxic stress, and it's fascinating, and I could stand up here forever and talk about it. But basically, when a child has adversity, they're in the fight or flight mode. The sympathetic nervous system is constant, and it affects hormone levels, and the hormone levels affect their immune system. It increases inflammation, and so the rates of chronic disease are much more increased, and it's more than just health risk behaviors. It's more than just behaviors and coping mechanisms of adversity. It's actually the biology of what's going on when there's toxic stress in childhood. So it's absolutely fascinating, and there's even more. It's still going on. They're still researching a lot of this in neurobiology, but there's epigenetic changes that, in fact, our DNA is changed. The way that it's transcribed and read in our bodies from changes from toxic stress can actually be passed down to children. So we talk about transgenerational trauma, and we talk a lot about an Indigenous health and intergenerational trauma. It's so much more than just experiences and parenting, and that there's actually, down to our DNA and down to like the telomere length, in our bodies has been affected by toxic stress. So it's huge, and I just found this a fascinating topic. There's also more types of ACEs in the last 20 years, lots of research and lots of changes to what kind of questions people have maybe added. There's new questions on discrimination, bullying, community violence. And so it's the last one. Because I'm out of time, but the project's still going on in NALA. My practicum hasn't really stopped, and we're still talking about who we're going to screen, how we're going to screen them, and we're making consents at the moment to screen adults. So thanks to everyone at NALA, primary care, the CEO Tracy, Dr. Simone Dowling, my lovely supervisor, to obviously Nigel, and everyone in the staff here at the school. And I had to put one last koala picture. Because this has taken 5 years of a degree. Like, it's just been the longest, Faye, I know you know. And so I found a koala that has 3 babies, because I have 3 babies. And I need to thank them for putting up with me and working shift at the hospital and blah, blah, blah. So this is just the cutest picture. So there you go. Thank you very much. Lots of hands.
Thank you so much. That was a really awesome presentation.
There you are.
Yeah.
Thanks.
And very inspiring to see your passion for the topic. It's awesome. You're just glowing up there. It's awesome.
I love this topic. I literally could talk all day on it. So
this is great. Okay, well, we have quite a few, so we'll try and get a couple in.
Hi, that was really, really interesting. Thank you for that. I have a question about the barriers to screening and what you came across in terms of building buy-in, like techniques for building buy-in or what worked, but also what are some of those procedural or personal barriers within health providers to doing that screening and asking those questions?
Yeah, thank you. That's a good question. That comes up a lot in the research, because that's what so many people come across when they try to present ACEs to really busy practices. So I think for the barriers, mostly time and sensitivity issues that doctors necessarily don't want to ask about, or they don't have time. But it sounds like breaking the barriers comes with the comfort level and making sure that the doctors or nurses or whatever health professional has a comfort level of asking questions and a good rapport with patients. And also that time-wise, I mean, some of the research just looked at how long it took. And if you tell a practitioner it will only take an extra 5 minutes, or if even the clinic can add an extra 5 minutes onto consults, then the long-term effects are worth it. You know, so it was trying to break down that it doesn't necessarily take too long. Some practices have patients fill out a screening in the waiting room, confidentially in the waiting room on a clipboard, and then they can come in and they can talk about it if they like, or they don't have to talk about it, they can just submit it, or they don't have to fill it out at all. And so it was hard, because every clinic wants to do something different, but the one that I was working at wanted to do it with the patients, and a lot of the patients need interpreters. 1 in 7 of their patients use an interpreter. So that creates a problem. You can't just give them a form in the waiting room. So it was trying to talk about the time that it might take, but the value later on, and identifying patients that may need different types of screening, or they might need more preventative health or more parenting programs or whatever, and it's how important it is to identify them, and maybe that we can make time for it. And the barrier as well, it's kind of like, you know, as one of the doctors stood up and went to presentation, she's like, we're doctors, like, why, we can ask about this stuff, you know, we can, like, it's, you know, and if there's someone they can be comfortable with, it should be their primary care practitioner. So I hope that answers it.
Hi, thanks very much. Ali is being sneaky because that's her thesis question. So
Oh,
she's gathering information from me.
We should talk. We should talk.
So my question is a little bit to do with screening and flexibility with the screening process to overcome some of the resistance, because I've worked in similar services and you don't have a lot of time.
Yeah.
So I'm wondering, is ACEs a point-in-time measure, or because it's a primary care clinic, could they build the information over time and as rapport builds with a practitioner and a client?
Yeah, that's a good question. That would be good. I know that for Anala's point, for their hope was to have a set ACEs score. They wanted the number. I think ideally, and with the researchers at the university, they would like to publish, and they'd like to have a proper ACEs screening pilot. And they wanted to use a standardized tool, and they wanted to have numbers, and they wanted to kind of have a sense of what are the ACE scores of their population. And it's such a vulnerable community, and there's such high rates of chronic disease, and they figured that they will probably get higher numbers, and that would show the need for the community, which can in turn get more programs, et cetera. So I think they're really interested. This specifically, they really want that proper score, and they wanted it in one 10-point
so that
question.
They can inform programs. So there's something similar here that we do with mental health clients, but we can update the scores as we go.
Okay.
So we can gather an initial score, and you don't have to do it in person. You can gather in-person information, but you can gather information from like their online profile and from other people.
Okay.
But you can update the score. So if you've been working with someone for 6 months, you can send a new score in, and that will continue to inform.
Wow, that's great, because you might get more information as the relationship builds.
Yeah.
That's good. Okay, it's good to know.
Excellent. Thank you. I think we could talk about this for a long time.
We could.
But we're out of time. Thank you.
Okay, thanks.